Obviously, most of you already are, believe that what I'm about to speak to you about today is of great importance, just as important as your physical health, which of course I think goes without saying is an obviously very important asset to all of us. But what I really want to talk to you today about is my journey in a career in science that has sought to really demystify mental health, to democratize mental health, to make mental health not only something that any and everyone in the community can understand, but more importantly, something that anyone can actually do something about to help others in the community. But first, let me just tell you what I'm going to take you through in the next half an hour. I'm going to talk about the challenge very briefly about mental health problems, the opportunity that global mental health, the science that I'm most deeply associated with, has generated over the last decade, and what the future would look like applying that science to reimagine the mental health care systems of India and indeed all countries around the world. The challenge is huge. This particular chart comes from the Global Burden of Disease study. This is a study that looks at the burden of all health conditions, over 300, and looks at the relative proportion of the overall burden of disease. Imagine the overall burden is a pie chart of 100%, for example, and you're looking at the percentage of different health conditions accounting for that overall burden of disease. And what you can see here is that between 1991 and 2016, over a 25-year period, no matter what country you're in, the countries are organized according to their development status. The poorest or the least developed countries are in this light blue line, and the wealthiest countries on the red line. What you can first of all see is that in all countries of the world, the relative burden of disease that is accounted for by mental health problems has risen 50% in the last 25 years. And what you can also see is that as countries become more developed, as they move from less developed to more developed, the relative burden increases. And that is really because of a number of factors, one of which is the failure, the success in richer countries controlling many other health conditions that are still very common in developing countries. For example, many infectious diseases, maternal and child health conditions, and so on. So as it were, the space on the pie chart for mental health problems expands, and so the relative burden increases. Put another way, as countries become more developed, unless you do something about mental health problems, the burden of mental health problems as a relative share of the overall burden of disease will keep increasing. Another very important fact about mental health problems is that they are health problems that hit the young. I would assume this is a large portion of my audience today, young adults between the ages of around 15 to 30. And what you can see on this slide, again, coming from the global burden of disease, that during this phase of life is when you see the biggest hump of the relative burden of mental and substance use conditions and self-harm. Let me see if I can remove this. Sorry, I'm just trying to remove this irritating Zoom window that is showing up, which I can't actually seem to do. So let me just put it here. So what you can see here is that between the ages of around 10 to 30, if you add up the blue bars, which is mental and substance use disorders, and the gray bars, which is self-harm, and let's just take this particular age group of 20 to 24, I suspect many of you are in this age group, and you add up the roughly 5% to the 17%, you'll see that about a quarter to a fifth of the entire burden of health problems in young adults is due to mental health problems. Now, in India, the impact of this is pretty dramatic. The single leading cause of death in young Indians today and for the last 10 years has been suicide. And of course, suicide is the most extreme outcome of mental health problems. Now, unlike most other health conditions, if you consider, say, for example, cardiovascular disease, many kinds of cancer, and so on, you will find that thanks to investments in science and the application of those investments in the real world, that there has been a declining prevalence. For example, the prevalence of strokes, heart attacks, and mortality associated with these conditions has actually been falling in most parts of the world. Not so for mental illness. This is a slide that comes from the US. And what it shows is that regardless of how much money and resources spent on mental health problems, the US has more resources than any other country in the world. In fact, it has 1,000 times more resources than India. There are more Indians who were trained in psychiatry who are working in the US today than in India itself, just to give you a sense of what inequity there is in the distribution of specialized mental health resources. In spite of the enormous amount of money the US spends on mental health care, there is virtually no impact on the prevalence, how common a mental illness is. And again, here you can see these lines according to age bands. The overall is in green, but what I want you to see here is a very interesting and worrying trend that when it comes to young adults, the prevalence has risen from about 18% to now nearly 22%, which is a very significant increase in the prevalence of mental health problems in this period. Indeed, in the US and also in India, suicide rates have been rising. In young Americans, suicide mortality has increased 50% in the last 10 years. In India, the data are much more recent, but there is an uptick, and you see similar rising trends in young adults in many, many countries around the world, which is something we should be very worried about. And of course, this is even before the pandemic. The pandemic will have made things a lot worse. This study that comes again from the Global Burden of Disease group, which was published in The Lancet just a few weeks ago, I've highlighted the main findings of the study. What it says is that the locations hit hardest by the pandemic, measured by decreased human mobility and daily COVID infection rates. Think about the first lockdown in India, the harshest lockdown anywhere in the world, which completely paralyzed human mobility. And think about the second wave that happened in India during April last year, where the latest data from a paper published in Science last week suggests that the true death toll was 6 to 7 times higher than the official death toll, making it the highest death toll in the world. So India has been hit hardest by both of these factors, that these were the factors associated with the greatest increases in the prevalence of depression and anxiety. And these authors estimated an additional 50 million global cases of depression completely attributable to the COVID pandemic. I want to end this challenges part of my talk with a very sobering reminder from Tom Insel, the neuroscientist, a dear friend of mine, who is the former head of the National Institutes for Mental Health, the world's largest funding body for neuroscience and all the related clinical sciences to do with mental health. His words speak for themselves. It turns out that unlike any other research investment in any other area of medicine or public health, no amount of money, $20 billion, during his tenure has produced an impact on the metrics that count the most: suicide mortality, the burden of mental illness as measured through the DALYs that I showed you earlier, or more social indicators, for example, the people with serious mental illness who are either living on the streets or homeless, who are incarcerated in prison. Now, one has to really, before one thinks of the solution, is to really ask this very important question: why have all countries failed to address mental health needs equitably? In no other area of health would you see such a gigantic failure across all nations of the world, regardless of the money they have. You know, it's not uncommon for us to say, yeah, India doesn't do so well when it comes to maternal and child health because we don't have enough doctors and nurses. And, you know, that is a reasonable explanation, because if you look at maternal and child health outcomes in the US or Europe, you'll find that they're doing extremely well, very low rates of maternal and newborn mortality, but not for mental health problems, as we've just seen. So there's something fundamentally problematic in the approach that the world has been taking to address mental health needs. And these are, in my view, the singular most important challenges. The first is a narrow, binary, biomedical framing of mental health into disorders. That is a problem that is fundamental. Whereas this use of diagnostic framings works very well for infectious diseases like TB and COVID, it does not work for mental health problems, which are in their very nature dimensional properties of every human experience. Dividing a dimension artificially in a binary way essentially misses the fact that at every point in our life, each and every one of us is somewhere on a spectrum from good to poor mental health, and that mental health itself comprises a number of different dimensions that do not map onto the diagnostic categories. There's a lack of attention in our programs of care and prevention to the social environmental determinants that have been shown repeatedly to influence brain development, and ultimately the experience of mental health and recovery from mental health problems. There's a lack of a life course approach, even though, as I showed you earlier, something that we've known for decades, that mental health problems are predominantly problems of young people, that they have their onset before the age of 24, unlike cancer or heart disease, which have their onset after the age of 35. Mental health problems are young people's problems, which means that they start in youth, and that means that there's something happening in the first 15 to 20 years of life that we must act upon if we are to stop the onset of mental health problems. But unfortunately, if you look at how mental health programs are organized, they're all about treating problems way after the horse has bolted, way after mental health problems emerge in childhood and adolescence. There's a lack of skilled providers. This is, of course, true of all health areas in India. This is not only true of mental health. We have a lack of skilled providers, particularly if you see the issue of skills narrowly through the lens of degrees and professional qualifications like MBBS or MDs. If you look at it only through that lens, we are short of skilled providers. There's also the problem that there's a reluctance in the general population to seek help from psychiatrists and psychologists because of the enormous stigma, but also because of the enormous cost attached to seeing these highly qualified professionals, and of course, the enormous barriers of access. In very many parts of the country, there are simply no mental health professionals at all that you can access, even if you have the money. And then, of course, there's the disempowerment of available resources. And this is a problem that Indian innovators have experienced in the health sector for decades, ever since independence. And I think that this is the environment in which some of the most creative and innovative, impactful ideas have emerged. An environment of scarcity of a resource has compelled scientists to begin to collaborate with communities to identify how can we address the lack of specialized resources in the health sector by empowering the resources that exist in every community. When I returned to India after my training in Britain in the mid-1990s, I was deeply inspired by this book. People's Health in People's Hands was actually published well before the mid-90s, edited as a collection of essays by Dr. Antia, one of the great, one of the iconic leaders in the marriage of medical science with community participatory action, who, as a plastic surgeon, didn't do cosmetic surgery for wealthy people, but instead worked with communities on how one could reintegrate people who had horrible deformities due to leprosy back into their communities through a combination of medical science in the form of reconstructive surgeries, as well as reintegration and rehabilitation of people into their communities. It's in reading this book, there were many, many different inspirational examples, but it's reading this book that I came across one inspirational example that has really been at the heart of a lot of the work that I've been doing. And that inspirational example was of this woman, Anjana Bai, that you can see here being trained really on how to weigh a baby. This is a woman who works in Gadchiroli, one of the poorest tribal districts of India, bang in the middle of the country, in the eastern edges of the state of Maharashtra. This is the kind of woman who was trained by Abhay and Rani Bang, two physicians who trained in India, went to Johns Hopkins to do their masters in public health, and returned and set up shop in this poorest of districts of the country, and discovered that there were no neonatal experts, no gynecologists, no obstetricians who could help work on reducing the astronomically high mortality rates that mothers and newborns were facing during childbirth and due to infections soon after childbirth. So what do? They turn to working with the community to identify helpers in the community, such as Anjana Bai, who could be trained in basic principles of evidence-based medicine to save newborn lives. That included skills on how to weigh babies, how to assess fever and diagnose infections, and deliver in medical treatments, such as, for example, injectable antibiotics for babies who they had diagnosed had sepsis. Remember, these are women who had not even completed high school, let alone actually gone to a college. Of course, as you can imagine, when Abhay and Rani began pioneering this work way back in the 80s and 90s, there were howls of protest from the medical lobby. It said, my goodness, this was terrible. This was so dangerous. And of course, they argued and said, well, excuse me, but there aren't any doctors in this part of the country. What do you want us to be doing? Watching mothers and babies die of conditions that were completely treatable? Isn't it ethically sound for us to at least train who we can to provide those life-saving treatments? And they said, well, the medical lobby said, well, prove that this is safe and effective. And that's exactly what they did. They went on to conduct what is often considered one of the most impactful randomized controlled trials in the history of medicine in India. That was published in the Lancet Medical Journal, the world's leading medical journal, demonstrating that this home-based approach of community workers or helpers diagnosing and treating newborn infections dramatically reduced neonatal mortality. A remarkable example of how medicine met community participatory action, met the highest quality of science, ultimately leading to such an impactful publication that led to this model being replicated in a number of sites in India and in other countries. And ultimately, this particular approach was embraced by the government of India in these operational guidelines you can see here, and ultimately the rolling out of the largest community health worker program in the world, the ASHAs, numbering more than 1 million, who have collectively contributed to the dramatic reduction in infant mortality in India and maternal mortality. Mind you, the maternal and infant mortality in India that has fallen in the last 20 years is almost 90% due to this intervention of home-based care and support by the ASHAs to mobilize mothers to have their babies in hospital. It is not because of very specialized interventions, it's because of this very basic community delivered intervention. Back in the early 2000s, when I was struggling to figure out how we could address the large unmet needs for care for mental health problems in India, I was deeply influenced by this work. I visited Gadchiroli. I read all about the work that Rani Abhay and many others were doing in other areas of medicine. And I wrote this manual, really inspired by their work. At that time, there was no real randomized controlled trial, no real evidence that in fact, such an approach was safe and effective. Even then, my book found many takers across the world. These are just some examples of the dozens of translations. The book also became the standard manual for the International Red Cross and MSF for their frontline workers in humanitarian contexts. But I was not happy with just simply writing a manual that was advocating and supporting the training of frontline workers to deliver mental health care without there being a robust scientific justification for it, evidence for it in the same kind of way that Rani and Abhay Bang had generated for newborn care. And that took me to a tremendous opportunity. And that opportunity was the rising field of global health. And within that field, I was one of the leaders in developing the mental health subdiscipline of global health. As you can see from this definition of global health, into which I've inserted the mental health pieces, this is an area of study, research, and practice. It's not just research in an isolated silo, but research that combines implementation and real-world delivery, that places a priority not just on improving a health outcome, but very importantly, achieving equity or justice in how that health is experienced and resources for those health problems accessed by all people in every country. In 2007, in the same journal, The Lancet, I led a series of articles that laid the foundation for the field of global mental health, 6 articles documenting the state of mental health care and unmet needs of care around the world, and ending with a call to action to scale up the coverage of services for mental health problems in all countries, but especially in low-income populations in those countries. And of course, that was most of India. And we called for the scale up to be based on 2 principles, that there had to be a solid scientific foundation on the evidence of what interventions were being scaled up, that these were interventions that must be shown to work in randomized controlled trials. And we had to twin that with a respect for the human rights of people with mental disorders, because we knew that the human rights of individuals with mental health problems, particularly serious mental health problems, were being gravely abused in all kinds of sectors of society, not least in hospitals of mental health care, where extreme forms of human rights abuse and violence were being experienced by people with mental illness. A few years later, Tom Insel, the head of NIMH, invited me to co-chair the Grand Challenges in Global Mental Health, a research priority setting exercise launched by the National Institute for Mental Health. The Grand Challenges in Global Health are an initiative that were launched actually by the Gates Foundation to identify the leading research priorities, which, if funded, could actually shift the needle on a particular health problem. The original Grand Challenges focused on maternal and child health, infectious diseases, and non-communicable diseases. This third edition of the Grand Challenges focused on brain conditions, mental, neurological, and substance use conditions. We identified a large panel of experts, 400, involving a range of different disciplines: neuroscience, clinical practitioners, people with a lived experience, researchers, and policymakers, and asked them what the leading research questions were that, from their point of view, that if invested in now, could lead to a dramatic reduction in the burden of mental health problems. We published our findings, a set of research priorities, in the journal Nature. And perhaps not surprising now, that the leading research priorities were delivery questions, not questions about discovering a new gene, a new molecule, a new neural circuit, but about doing better with the research, with the knowledge we already had, by making that knowledge available to more people in every community, in every country of the world, what we call implementation science. 10 years later, I can tell you, with more than $1 billion of new money backing these grand challenges, that we know how to deliver clinical and preventive interventions in an affordable and acceptable way in any resource setting, such as this image here in Zimbabwe, where the woman on the right is a grandmother from the local community delivering a 6-session psychological treatment for people with depression, such as the woman on the left, who is a mother with depression, referred by a nurse in the primary health center at the back there to see this grandmother therapist. And what is this intervention called? The friendship bench, because it is delivered on this wooden bench that's been erected under a tree in the compound of the primary health center. I have worked over the last 15 years with the NGO Sangat in Goa, and we, as you can see from the titles of these many different articles published in leading journals like JAMA and Lancet and so on, have been working on designing interventions for the delivery by lay and community health providers for a wide range of mental health conditions, from autism in childhood to adolescent mental health problems in schools, to schizophrenia, depression, and drinking problems, all the way through to supporting older adults with chronic diseases. And in the next slide, in a video, I want to show you really a snapshot of what this intervention looks like and is experienced by people in the real world for a program that we ran for people with schizophrenia, one of the most severe chronic mental health conditions. This was a trial we ran in 3 sites in India, in Satara, in Maharashtra, in Goa, and in rural parts of Tamil Nadu. And the video will speak for itself.
So एकदमच मला कम से कम 5 मिनिटं आवाज माझ्या कानाला फिरत होता. मी देव बोलतोय असं तसं.
मानसिक आजार हे काय असतं हे मला याच्याबद्दल काहीच माहिती नव्हतं. म्हणजे हा प्रकारच माहित नाही. पण मला काहीतरी म्हणजे समायोजित वर्तनात काहीतरी आहे असं मला सारखं वाटायचं. पण कोणापुढे बोलायचं हा एक माझ्या मनामध्ये कुचंबणा व्हायचं.
आजूबाजूची लोक ते दृष्टिकोनातून बघायचे, तिच्या येडीचे हसती बघा कशी. कोण माणूस पुढनं येणारा असला तरी त्याला असं वाटायचं ती माझ्याकडेच बघत हसली म्हणून तो माणूस असा बघत उभा राहायचा. मग मी ती उभी राहायचे. मी 2-3 माणसांना बडावलेलं बी आहे त्याच्यातनं.
वाईट वाटायला लागलं की झाडाला धरायचं रडायचं. कोणाला सांगायचं नाही पण काय असं आहे म्हणून.
तसं जर देव वगैरे केलं लाग भांगेल लय केल्या बरं का. देवाला ह्या देवाला जात त्या देवाला जात त्या अमक्याला पळा कुणीकडे पळा लांब लांब ले जो 5-6 महिने आम्ही राखवलं देवासाठी. प्रमाण उलट देवाला वगैरे जास्तीच वाढायचं पण कमी नाही.
कॉप्सी हा प्रकल्प जो आहे तो त्याचा लॉंग फॉर्म असा आहे केअर ऑफ पीपल्स सिझोफ्रेनिया इन इंडिया. म्हणजे औषध उपचाराव्यतिरिक्त जर काही सामाजिक उपचार पद्धती जर या लोकांना चालू केली.
डॉक्टर आणि पेशंटच्या मधला दुवा असा आमचा रोल होता.
ते म्हणलं पाठवा की सर बरं होईल. कारण आम्हाला माहिती येते कसं कसं काय गोळ्या द्यायच्या, कशा काय करायचं किंवा काय करायचे, कसं त्याच्याशी वागायचं, कसं काय हे म्हणलं आम्हाला माहिती पडेल.
हे तुम्ही जे प्रोग्राम हे ठेवलं होतं ना, हां, तर त्याचा पुरेपूर फायदा आम्हाला झाला आहे. म्हणजे औषधांचं तर झालंयच, पण औषधांपेक्षा पण ते जास्त म्हणजे संभाषणाने ह्यांच्याशी व्हायचं ना, बोलायच्या.
जोपर्यंत जमेल ना तोपर्यंत तरी काम असावं आपल्याला असं वाटतं. जोपर्यंत जमेल तोपर्यंत. दिवसभर म्हणजे काही विचार वगैरे काही येत नाही. दिवसभर याच्यात मन रमतं ना.
आता जरा बरं आहे, आधीपेक्षा बरं आहे. म्हणजे कामाला पण जाते, त्यामुळं शाळेचा खर्च आधी नव्हता, पण आता खर्च आलाय ते मम्मी भागवते.
Work is not just for money. It is for self-esteem. It's what you think about yourself. It's the way you spend your time. It's your productivity. It's what you give to society, what you get from society. So when they start working, then they feel much better. People learn to respect them. They start liking themselves.
आत्ताची परिस्थिती आणि त्या टायमाच्या परिस्थितीमध्ये किती आसमानचा फरक. म्हणजे माझं कारण म्हणतंय की इथून पुढं जे तुम्ही चितलेलं काम आहे, म्हणजे जे माइंडमध्ये तुम्ही ठरवलेलं आहे, पुढं लय त्याचं चालना मिळणार नाही.
So I coined this acronym. Some of you may have seen my TED talk from a few years ago, which I actually coined this acronym for that TED talk. What are the ingredients that go into this kind of design process for making effective mental health interventions available in these rural, remote, far-flung communities that optimize acceptability and feasibility? And these are, my acronym was Sundar. Of course, all of you speak Hindi or many of the North Indian languages will recognize that, that's a play on the word Sundar. But these are the ingredients. We need to simplify the message, break down the complexity of these medical interventions into their component active ingredients. By unpacking that, you can then deliver these using affordable and available human resources where people are, rather than where the professionals are. And in this way, improve access to care in an affordable way. And you can then reallocate the few specialists this country has to perform more specialized tasks, such as referral tasks and training and supervision. This evidence has transformed mental health globally. 10 years ago, I would not have been able to tell you that the World Health Organization's Mental Health Action Plan or the World Bank's Disease Control Priorities Program, or indeed at the level of India's national mental health policy, would have said that the single most important priority to transform mental health care around the world is by actually promoting the building of skills in the community of non-specialist providers to deliver psychosocial interventions. Indeed, to my greatest surprise and pleasure, particularly now that I work at Harvard Medical School in the US, when last year the RAND Corporation released a very important landscaping analysis report on how to transform the US mental health system, look at what they recommended. A country that has 1,000 times more mental health resources than India was calling for taking a model that emerged in India by training non-specialists to deliver frontline mental health care, even in the US. And this tells you something very important, that it's not just about how much money you spend. It's not just about how many specialists you have. It's actually about completely reimagining who is a mental health provider, what mental health care do they provide, and where that care is provided. And importantly, it also shows the importance of the entire pathway of science. For much too long, much of the funding in the mental health sector has really focused on phase 0, 1, and 2 in this translational continuum, on basic science discovery of genes, of new molecules, of new neural circuits, and doing early clinical trials. But what we've shown now, that what finally makes a huge impact is if you make sure that you also invest in the later kinds of science further down the line, that is to say the science that is associated with taking basic lab discoveries and making them applicable to real human beings, and most importantly, ultimately, that can be adopted implemented at scale. I want to close by really thinking about the work that I'm doing now, the future, what excites me, and how I'm taking this agenda forward in what I consider now the last phase of my own scientific career. A few years ago, the editor of The Lancet invited me to lead a major new commission for the journal on global mental health and sustainable development. Of course, the SDGs have become a very important framework for thinking about the place of science and medicine within the overall scope of sustainable development in all our communities. And we brought together all the evidence that I've briefly shared with you, but also many other kinds of evidence, for example, the revolution that digital technologies have afforded us, and came up with a set of recommendations for a reframed mental health system. Firstly, that we had to abandon altogether the very old diagnosis-focused system of mental health care, which focused on a diagnosis by a psychiatrist and often a prescription that followed, but recognize that we can intervene across an entire range of degrees of severity of different dimensions of mental health experiences. To do that, we also had to therefore emphasize prevention that targeted particularly the structural and social determinants in the early life course, particularly maltreatment and neglect in childhood and adolescence. For people with serious mental illness, we needed to have a rights-based approach to eliminate coercion and institutionalization in mental health care. And ultimately, the foundation of every mental health care system really had to be on the scaling up of psychosocial interventions using community-based providers such as community health workers, peer support specialists, and indeed just lay people. And so I want to end by telling you what I'm doing in order to make that a reality. 2 years ago at Harvard Medical School, in partnership with Sangat in India, we launched an initiative to actually achieve exactly that goal. The scaling up of psychosocial interventions through empowering ordinary people in the community health workers, nurses, midwives, peers, to learn, master, and deliver evidence-based psychological treatments using a suite of digital tools. So this was not a digital app for people with mental health problems to learn how to fix their own minds, but instead a digital platform to train frontline workers to deliver in-person care, which is what most of us actually want when we have a mental health problem, and to inform and empower the system with data to understand what impact that is having in their population. So this just shows you a kind of an infographic of the suite of digital tools and functionalities, from learning management systems, competency assessments, all done digitally, supervision and support to support the mastering of the psychological treatments, continuing quality assessments, decision support when a provider is faced with multiple different kinds of mental health problems and needs to know which clinical intervention to deliver. And at the level of the system, as large numbers of providers are providing care, a range of data science driven opportunities, for example, prediction models to refine treatment selection and evaluating impact at scale. So there's a combination of some pretty basic digital technologies here with some very sophisticated advanced data science, which actually can't be done at all if we continue doing business as usual. The seeds of Empower were laid 10 years ago when I developed and designed a 6-session treatment for depression called the Healthy Activity Program that was trialed in Goa first and replicated in a trial in Nepal, and now has been adopted by 3 centers in North America and adapted for maternal depression, making it the first time that a clinical intervention developed in India for lay health workers is now being used in North America. We designed this intervention, is now also being used in many African contexts. And what we decided was what we needed to do was to now train frontline workers to deliver this intervention using an online curriculum. We've designed that curriculum. We've completed a randomized controlled trial demonstrating that coach-assisted digital learning was just as acceptable and effective as the gold standard of in-person learning. Why do we do digital learning? Well, primarily because to train the million ashas who we need to train to deliver this brief psychological treatment, we can't do it through a workshop model. It's simply never going to happen. The cost, the time needed, and also the disruption in the daily life of the asha is too huge. So this is a model of creating high quality training, because of course the training content remains exactly the same. There is nothing lost because the trainer has changed, and you can do it on your own time and do it in a rapidly scaled up way. So we're now scaling up this training through a complicated platform of both training as well as supervision and quality assurance in 3 districts of Madhya Pradesh. What's been really remarkable is Ashas, most of whom have not passed the 12th standard, take to this training so well. 95% of them completed the training. The feedback we got was amazing. And importantly, their competencies were as good as those Ashas who in a comparison group received the gold standard training. But what's really exciting is we're replicating the same work in the US. Last year, I won a $10 million prize along with colleagues in Texas, where we're taking exactly the same model that we designed, developed, and implemented for the first time in India. We're taking it to Texas with support from a number of different partners, as well as this prize money over the next 4 years. This same brief psychological treatment for depression will be scaled up in the hands of community health workers and nurses in one of the wealthiest countries of the world. Ultimately, what we envisage and think of is a mental health care system where evidence-based psychological treatments can be delivered in the community through empowered providers, very many different kinds of providers who act as an outreach, a extension of the footprint of the mental health care system. In closing, we're going to need to do something about the rising demand of mental health problems. You already saw earlier that not only was the unmet need for care huge. By the way, I don't know if you're aware of this. The government's own statistics show that 95% of people in India with a mental health problem do not have access to mental health care. 95%. This is the government's own data from the National Mental Health Survey. And this was before the COVID pandemic. And you just saw that the COVID pandemic is going to massively increase demand. If we stick with the current system, which only help 5 to 10% of people, you can imagine the unmet needs for care are going to even further increase. We need a radical transformation by implementing the science that I've shared with you today if we are going to increase the number of people helped. In closing, this is a historic opportunity for us to invest in mental health care. COVID has shone the spotlight like never before on mental health. And while we certainly need more money, we also need to spend it wisely, guided by the best science. And that best science that I've shared with you today shows that mental health care must go beyond the narrow biomedical and embrace the diversity of experiences and strategies that science has shown work and can transform lives. Thank you very much. And I'm now going to turn it back to you, Shruti.
Thank you so much, Professor. That was absolutely lovely. And if I can just add to what you said, the video that you showed, that was absolutely moving. It was so lovely to hear from all of the speakers in that video. I mean, I could see that they really were speaking from the bottom of their heart. Their emotions were up on their sleeve. It was really lovely. And thank you so much for touching upon such pertinent topics. We have so many questions for you. I'm just going to quickly fire them up so that we can cover as many as possible. The first question that we have here is, if someone is facing a mental health issue, who are we supposed to approach? We're students, we might not be comfortable sharing it with parents, and we don't have enough money to see a psychiatrist or a psychologist. What's the first step to address mental health?
Well, I can tell you honestly that this has been a huge challenge this is exactly my point that I made. The good news, I can tell you there is good news and that's come out of the pandemic, is the tremendous adoption of teletherapy. So today you don't need to be near a therapist. You don't need to have any of the embarrassment of walking into a clinic that says therapy. You can access care online. And the other good news is a lot of that care is free. For those of you who would like to access care for free with very experienced mental health professionals, log into the Sangath website. There is thanks to COVID, Sangath has been able to mobilize resources to offer a free online teletherapy by highly qualified professionals. So I can tell you right away, that's the place to go where you can get care without leaving your home at all.
Thank you so much. If I could just request the moderators to drop in Sangath's website link in the chat, I think that will be very, very useful for all our attendees. The next question that we have here is, do you think as budding psychologists, we should now focus more on community psychology that focuses on prevention rather than cure? What advice would you give to budding psychologists?
You know, for me, psychology is one of the most exciting sciences. And, you know, to me, it is along with neuroscience, psychological science and neuroscience together. Psychological science is so diverse. From, you know, from cognitive neuroscience to the kind of science that I've just, you know, talked about, clinical sciences and its application. I don't think any one of those is more important than the other. I would like you to think of the entire translational spectrum from discovery to delivery as being important. And your place depends on where your heart is. Honestly, I think you've got to be driven by your passion. If we did not have the basic discoveries that laid the foundation for those psychological treatments, we would not have any treatment to deliver at scale. So I have enormous respect for those people who spend a lot of their time in animal labs, because some of the original behavioral experiments were done with animals that then led to translation into human subjects, that then led to translation into populations. And I work at the more population end, but I don't believe that any one of these is more important than the other. They're all equally important, but you don't have to do it all. You just have to go to that part in that translational continuum that makes you most excited.
And I mean, I think that's something that so many researchers on our platform have said, that if you are excited about the work that you do, you will produce good results. I was very thrilled to see the example of search at Gadchiroli that you quoted, because Professor Dr. Abhibhag was actually part of our festival last time. And he told us about the community health practices that he had adopted in his work at Gadchiroli. And I think that brings me to the next question. Do you think that while promoting the cause of mental health, there are some specific things that you have done that have worked for you? And is there some specific tool that you have used which has worked very well while talking about mental health to non-specialist audiences?
Well, yeah, absolutely. I would say the single most important thing is to demedicalize it. The moment you apply medical labels, which are filled with fear, with shame, with anxiety, you actually, first of all, you create more anxiety. And secondly, as I explained to you earlier, these medical diagnostic constructs that were invented, there was no scientific proof to them. They were invented for good reason back in the 70s, because there was felt that by having descriptions that involve the clustering of symptoms that were observed in the clinic, you would create patient groups that would then enable you to discover some core pathology. That never happened. And now we know that actually the most parsimonious, the most effective way to describe mental health problems is a series of dimensions. And there are very good dimensional systems that are out there. I won't go into details. So there's no scientific foundation in those labels. And more importantly, those labels are associated with enormous confusion in the mind and anxiety. So for example, rather than telling somebody you have this clinical condition called depression, I literally paraphrase, or we train the health workers to paraphrase and say, look, you're not sleeping well at night, you're getting these terrible thoughts about your future, and you're even thinking of harming yourself. This is because your son has just lost his job and you're worried about him. So you're connecting the etiology with the actual symptoms, and that immediately makes the person at ease and say, yeah, you heard me. You didn't just say here's your illness diagnosis and give me a prescription. So I think humanizing and demedicalizing the experience of mental health problems has been the most powerful anti-stigma strategy that I have found in my work.
It's very well put. So humanizing and demedicalizing stays. So the next question that we have here is, can you tell us about your work with young people while working on mental health interventions, specifically with respect to the work done at Sangat? How have you involved young people to be involved in different mental health initiatives?
Yeah, well, that's been one of my most passionate areas of work. That's one of the first things I started back in the 90s. One of my first papers was called Sex, Studies, or Strife. What do young people really care about? And the point I was trying to make there was that, the focus back in the mid 90s on young people's health was all about HIV prevention. And I wanted this enormously important subject of young people's well-being to go beyond just safe sex as being the single most important thing. Sex for pleasure, for example, the need for romantic relationships and how that related with people's well-being. This was being completely ignored at that time. And so that, my interest in young people, a broader youth-centered and youth-led definition of well-being has always been one of my guiding principles. And right through my work, the way I've done that is by always having young people advising me in very formal roles, not just in a tokenistic, informal way. And most recently, over the last few years, I've had a group of young people in Sangat who are leading our youth engagement. So they themselves are young. Of course, over years, some of them become a little older. But when they started, they were all very young. And they run some amazing youth engagement programs with support from the India Alliance, for example, from the Welcome Trust and others. Including something called Man Mela. You can maybe write that down in the in the chat box, www.manmela.org.in, which is a museum of the mind that is led by young people, that involves storytelling as a medium to destigmatize mental health problems, storytelling about one's mental health in very different Indian stories. And the stories are told through comic books, through poetry, a variety of different media. So, that's been one of the most enjoyable and rewarding parts. And it is through young people that I've come to the conclusion that a narrow medical approach will never, ever work. You can have psychiatrists and psychologists breathing down your neck, and yet it'll have no impact. It's not just a question of not having human resources. It's also a question of how you conceptualize this issue fundamentally.
One of my favorite things about speaking to scientists and researchers at the festival is how much importance they give to young people and don't dismiss them off, because young people seem to have the best ideas. They seem to be able to channelize thoughts a lot better than all of us. But so the next question that we have here is, do you think, what role do you think social media has played in mental health issues? And do you think that there is any way that we can really take time off from the screen time that we are forced to during the pandemic? How do we distinguish between the incessant amount of social media in our life and the kind of harm that it's causing?
So two things I want to say from the science. The first is that the effect of social media on the developing brain is very age dependent. When the brain is most plastic, which is in the first decade of life, obviously the impact of screen time will be completely different than when the brain is completely consolidated in its architecture in their 20s. And of course, the adolescent period, the youth period, is a kind of shoulder period between a highly plastic brain and a brain that is largely stable in its architecture. So as you grow older, the screen time effect is different. So there isn't a one-size-all-fits answer to the issue of screen time, according to how old you are. The second question is that in young people, which is a transitional phase of brain development, and during which most screen time actually is most intense, is when screen time really becomes greatly expanded. There's been very large population level studies examining longitudinally the association of screen time with mental health. And the net result of that is that there isn't a clear answer, basically saying there isn't a direct linear relationship, a unidirectional relationship between the amount or the type of screen time and mental health. It turns out that people using the same amount of screen time, equal proportion say it's harming their mental health, and equal proportion say it's actually improving their mental health. It turns out that what's more important are other things that are happening in the young person. For example, their pre-existing mental health and well-being. What is happening in their environment? For example, how are they engaging with peers in offline ways? Are they actually having offline relationships? What is the relationship like with their parents? How are they using social media? Are they using it for constructive things? For example, speaking to a grandfather who is, living somewhere far away to have conversations, etc. It isn't just a crude metric, how much social media do you use? It is likely to be an exquisite interaction at a very personal level between the person, the way and amount of social media they use, and their environment that actually helps us understand why for some social media is harmful, but for others, it can actually be very empowering.
So much, Professor. I think, time just really flew by. We have so many questions, but I think I can take one or two more. One of the questions that we have here is actually a very interesting one. How do we differentiate between having a mental health issue to being sad? How can we check on our own mental health on a regular basis? Are there any practices? Are there any patterns to identify that maybe we can keep in mind or share with our friends and family? And then we'll be able to acknowledge our mental health issues better.
So, that's a great example of a question that goes straight to my point about the binary. Just being sad is also important. You don't need to be having a disorder to acknowledge that you are in pain. Let me give you a good example. Supposing you're sitting around, supposing you're walking. stub your toe and it starts bleeding. Now, you're not going to run to accident emergency for that. You're not going to go to the orthopedic surgeon. Oh my God, my toe is bleeding. But you're not going to sit around doing nothing either, right? You are going to do something about that bleeding toe. You're going to take it home. You're going to wash it. You're going to put a bandage. And if it's paining a lot, you're going to speak to someone, someone close to you and say, look, can you get me a painkiller? That's what you got to do when you're feeling sad. You don't have to medicalize it. By having a dimensional approach, the whole point is you recognize that across the full spectrum of distress, at the extreme end of that spectrum, yes, these are clinically significant conditions with profound impairment that do need clinical interventions. But there are other forms of distress on that dimension that are equally difficult to live with, for which maybe you don't need a clinical intervention, but you can reach out to people immediately around you. The key step is acknowledgement, recognizing in the same way that you won't just sit watching your bleeding toe and say, oh, maybe it'll stop bleeding tomorrow. And you do something about it. When you're feeling sad, don't sit around waiting to think, oh, maybe it'll go away tomorrow. Say, no, let me just talk to my mom. Let me talk to my boyfriend. Let me talk to someone. Hey, look, I'm feeling really lousy right now. Because 99 times out of 100, that's all you need to do.
Thank you so much, Professor. That was so well put, and I'm so glad we were able to speak with you about such a pertinent issue. I would encourage all of our attendees to please look at all the resources that we've spoken about in this talk. There are so many links that we have dropped in the chat. Please do look them up. And Professor Patel, that has brought us to the end of this session. I'm just going to ask you one last question that we ask all of our speakers. You have been such an active proponent of bringing science to the masses and engaging in public engagement activities. How important do you think a platform like India Science Festival is to sort of bridge the gap between science and society? And what do you think these platforms, what is the role that they play in communicating credible science to masses?
I think they're profoundly important, Shruti. I mean, I'm so thrilled, first of all, to be given the privilege of speaking on this forum. For me, the COVID-19 pandemic has demonstrated the importance of good communication. I mean, if there's one thing the science community could learn is how do we communicate? We have been awful, by and large. Let's be absolutely blunt. I can see Shahid, who's joined. I don't know if Shahid will agree with me or not, but by and large, the science community has not been very good in communicating facts about the epidemic, whether it's about treatments or prevention or vaccines or whatever. And, it's easy to blame the public, but the public is also darn confused. Most people I know don't know who to believe anymore. So I do think that, we don't get training in science. We don't get training in communication just because we're good scientists. We publish in great journals. Or somehow people think you're magically, therefore, able to communicate. We now know that's not the case. We're not magically able to communicate. And I think, therefore, the ability to communicate should be integrated in every training of every scientist, particularly those sciences that are society facing, like, for example, clinical science and public health science. Equally, an opportunity for us to be challenged and interrogated by the community. We don't have forums like this. How often do you have, for example, the people making the COVID decisions being actually on a town hall? We should have that. In the US, you have that. You have Tony Fauci in a town hall where ordinary people can fire questions at him and say, why did you say to not to use a mask at the beginning of the epidemic and now you do? What's changed your mind? And we should be in a position to be able to explain that, because of course, science is a constantly dynamic process. It isn't the case you can sit back in 2 years ago and say, oh, he said that then, but that was what we knew then. But you need to be able to explain that. And when you do that, you win the trust of our community. If there is a certain segment of our community does not believe scientists anymore, there is no question about that. And to look at the anti-vax movement purely that these are idiots who don't understand, they're deplorables, etc., is not a helpful way to look at anti-vaxxing. It has to also look at the way, how do we communicate science more effectively to the general community? And I think you guys are doing a terrific job in that way.
Thank you so much, Professor. It was an absolute pleasure hosting you at India Science Festival. We really, really hope that we're able to host you for the next edition, hopefully in an offline, on-ground setting in India. And it would be lovely for you to engage with all of our audience members on a closer interactive level. So thank you so much for your time. On behalf of the entire team at ISF, thank you. And it's been an absolute pleasure.
Thank you so much. Thank you very much. Bye-bye.